Okay, I've been asked to talk about palliative care for patients with dyspnea and also about optimum use of life-sustaining treatment. The latter topic is becoming, I think, more and more important for two reasons. One is that life-sustaining treatments, including cardiopulmonary resuscitation, mechanical ventilation, hemodialysis, and even artificial nutrition via gastrostomy, can be harmful as well as beneficial. It can benefit patients more than it harms them, or it can harm them more than it benefits them. So one needs to be very careful about how to use it. And the second reason is that around the world, as countries develop, there are more and more intensive care units, more ventilators, more hemodialysis machines, and they're being used sometimes. There's an assumption, as there was years ago in the West, that any life-sustaining treatment should be used if it's available. And so the result is that sometimes suffering is increased and there's little or no benefit. So I think it's worth thinking about optimum use of these treatments. And as always, I like to begin with a patient, a man who has advanced COPD. He's short of breath at baseline, so 24 hours a day he's short of breath. He wakes up because of shortness of breath. He's sitting forward in his chair. He's very cachectic. He's used all his body fat just to breathe in the last few years. It takes so much energy. Based on his cachexia and his end-stage COPD, his life expectancy is short, but unclear how long he might live. So again, no disclosures, no financial relationships with drug companies or other commercial interests. In the next hour or 90 minutes, I'd like to discuss the best treatment for refractory dyspnea based on its causes, and there can be various causes. The treatment depends on the cause, and I'm going to emphasize that point. And based on the patient's values and the goals of care. And I want to emphasize the importance of goals of care also. And then I'll move on to describe the recent history of life-sustaining treatments, some principles for optimum use of life-sustaining treatments, and guidelines for optimum use of life-sustaining treatments. Okay, dyspnea. Odichka. Okay. Odichka. So odichka, dyspnea is very prevalent in not only COPD, but in many advanced chronic diseases. Also, so in COPD, in some studies, 98% of dyspnea. Cancer up to 77% in some studies, heart failure as much as 88%, and renal disease as much as 82%. There's a wide variety, a wide variation in the prevalence studies because some studies include patients with very early stage disease. But patients with advanced disease, it's very common. The pathophysiology is not completely understood. Any phenomenon of the central nervous system is typically not completely understood because the central nervous system is so complicated. but it's known that there can be a mismatch between the motor signals sent out by the brain to the skeletal muscle of the chest wall and to the diaphragm to breathe, and the afferent information coming back from chemoreceptors and mechanoreceptors. So, for example, if the brain tells my chest wall and my diaphragm to breathe, but my lungs don't expand because I have pleural effusions and ascites, that's interpreted as the brain, interpreted in the brain, and I feel dyspnea. Or if the brain is telling me to breathe, but my partial pressure of carbon dioxide, my PCO2, remains high, that's experienced as dyspnea. That's called the afferent mismatch theory. Maybe not extremely important, but just a little bit of pathophysiology. Assessment of dyspnea. Dyspnea, like pain, is a subjective phenomenon. There's no perfect objective measure of dyspnea. There are patients who are breathing very rapidly who deny that they have dyspnea, and then there are patients who seem to be breathing normally at a normal rate and seem not to be laboring who report dyspnea. So the most reliable measure is you have to ask the patient. It's not pulse oximetry, it's not blood gases, it's not respiratory rate. You have to ask the patient. If patients cannot talk to us or are confused, then we have to use some imperfect objective measure, indirect measure, such as respiratory rate, use of accessory respiratory muscles, the appearance of laboring, working very hard to breathe, gasping, sweating, open mouth breathing, wheezing, coughing, or the inability to speak in a full sentence, like that. Interrupted speech. The treatment, in most cases, needs to be based on differential diagnosis. And I will emphasize the concept of differential diagnosis. So, just to give you an idea of the very many potential causes of dyspnea, let's go through the differential diagnosis. So first, blood, pus, or fluid in the alveoli. Because of pneumonia, pus in the alveoli, or pulmonary edema, fluid in the alveoli, or pulmonary hemorrhage, or aspiration, so there's Bosch in the alveoli. Bosch doesn't belong in alveoli, belongs in stomach. That was supposed to be a joke, but okay. Airway obstruction from bronchospasm, from reactive airway disease, or thick secretions, or tumor, or foreign body. Tumor replacing lung parenchyma, or spread, whoops. Okay, so blood, pus, or fluid in the alveoli, airway obstruction, tumor replacing the lung parenchyma, or lymphangitic spread of tumor. Often lymphangitic spread of tumor is not seen on X-ray, and even with CT scan, unless it's a very experienced radiologist, they may find it difficult to diagnose. Inability to expand the lungs or the chest wall, due, for example, to pleural effusion or ascites, or pulmonary fibrosis, or neurologic disease, like amyotrophic lateral sclerosis or polio. Or from us, if we give long-acting neuromuscular blockade. Pulmonary embolism, very common, especially in our patients who maybe have cancer and aren't moving, they stay in bed all the time. And pulmonary embolism, like some other conditions like airway obstruction or hemorrhage or pulmonary edema, can cause sudden, severe dyspnea. Very sudden onset and very severe. So a palliative care emergency. Anemia can do it, and so many of our patients are anemic, either because of renal failure, their kidneys aren't making erythropoietin, or because of anemia of chronic disease from cancer or any other chronic disease. Metabolic problems. So very often patients near the end of life, as they start to become hypotensive and as their kidneys fail, they develop a metabolic acidosis. So many patients, even if their lungs aren't involved in the disease, develop dyspnea in their last hours of life, days or hours of life, as they develop a metabolic acidosis. They're struggling to have a respiratory compensation for their metabolic acidosis. They're struggling to get rid of CO2. So many patients are dyspneic at the end of life. And then psychosocial problems. Anxiety can cause dyspnea or any other sort of social problems. So the differential diagnosis of dyspnea is very large. And sometimes you don't need an opioid. You can treat the underlying cause. So I mentioned that the treatment needs to be consistent with the goals of care. And I'm going to talk more about goals of care later on when we talk about life-sustaining treatment. But even after you do the differential diagnosis, deciding what treatment to use often depends on the goals of care. What is the goal here? Is it only comfort? Or is that also extend life as long as possible along with comfort? Maybe the quality of life isn't so bad. The patient still would like to live longer if he or she can. Or maybe the first grandchild is being born next month and he or she would like to be alive for that grandchild being born. Or there's a wedding, or there's some other special event. So what are the goals of care? If there's bronchospasm, well, maybe that can be treated with with bronchodilator and steroid. Maybe opioid isn't needed. Pulmonary edema, maybe just intravenous furosemide, diuresis can do it. If there's bronchial obstruction, and from tumor or from a foreign body, and the patient is in a hospital that can do bronchoscopy, maybe the obstruction can be removed. Pleural effusion, the fluid can be removed, again, depending on the goals of care. Is this a patient who you would want to undergo an invasive procedure, a needle into the chest to take out the fluid or not? And for anemia, you can give blood, give red blood cells, depending on the goals of care. But for refractory dyspnea, or dyspnea in a dying patient, there's no better treatment than opioid. Opioid, like morphine, can take away the feeling of dyspnea. And there's very good data on this. There's really no question about it. Sometimes non-pharmacologic interventions can be helpful, and I'll mention those. Sometimes oxygen or anxiolytics can be helpful, but nothing is anywhere nearly as effective as opioid for relieving dyspnea that's refractory to treating the underlying cause or in a dying patient. in patients like the patient I showed on the first slide with end-stage COPD, many doctors, probably most doctors around the world, would be afraid to give opioid to that patient. They'll say, his PCO2, is it clear what's PCO2? People know what that means? PCO2, yeah. They'll say, well, his PCO2 is already high. It's 80 or 90. If you give more opioid, it'll go even higher and then he'll be unconscious. But what we found, and I don't know of any data on this, this is just from our own practice, from my experience and my colleagues. If very gentle, small doses of opioid are given to a patient like him who is uncomfortable all the time because he's dyspneic even at rest, if small doses are given and his respiratory rate is slowed just a little bit, often those patients are breathing rapidly and very shallow. So when a patient like that is breathing rapid and shallow, he's ventilating mostly dead space. He's ventilating large airways and injured lung. You slow down, you calm him down a little bit with a little bit of opioid, maybe he breathes a little bit more slowly and a little bit more deeply, and he begins ventilating the normal parts of his lung. So we've seen, we don't usually do blood gases on patients like him, but we've seen the PCO2 actually decrease after giving a little bit of opioid. And more importantly, the patient is more comfortable and can sleep better and has better exercise tolerance, can get out and walk a little bit because they're not breathing so rapidly and so shallow, and their blood gases actually improve. So you have to be careful. You don't want to give too much opioid because then the PCO2 will rise. But with very gentle doses, half of the usual, I usually give half of the usual starting dose. So for example, oral morphine, which a usual starting dose for an adult would be 5 milligrams, I may only give 2 milligrams. Or intravenously, instead of a usual starting dose of 2 milligrams intravenously, I'll give just 1 milligram and see what the result is. And sometimes it provides good benefit without changing the blood gas or even improves the blood gas. Other opioids can be used, but morphine is the most commonly available and the cheapest, and there's nothing that's any better for the most part. Maybe I'll just mention that if fentanyl is becoming available, especially the transdermal patches, the reason that the benefit of fentanyl, one of the big benefits of fentanyl over morphine is that the dose does not need to be adjusted for renal failure. So if you have a patient who has renal failure as well, and fentanyl is available and not too expensive, that's a good reason to use fentanyl. So if dyspnea is severe, so for example, a patient has their airway has been very small and now their airway is plugged. Their airway was reduced maybe by cancer and now something has caused it to close completely. Some mucus plugging and you're not able to relieve it, or pulmonary hemorrhage from a patient with tuberculosis. So sudden severe dyspnea, then opioid needs to be given in doses, in whatever dose is needed to relieve the dyspnea. And then it needs to be given either as a continuous infusion or every 4 hours around the clock, if it's an intermittent intravenous dose. There, fentanyl, if fentanyl is used, it can be given as a continuous infusion, but fentanyl, the duration of action of a single dose of fentanyl is only 1 or 2 hours. So in that case, morphine is better because it lasts about 4 hours. And if there's a patient who's getting opioid around the clock, either as a continuous infusion or as an injection every 4 hours, or as an oral dose every 4 hours, there should also be rescue doses available for breakthrough pain or breakthrough dyspnea. And I think most palliative care people are familiar with that concept. Yeah, okay. If you just follow the international guidelines, follow the usual guidelines for dosing opioid, respiratory depression is very rare. So all around the world, I find that doctors learn in medical school you can't give opioids. You have to be very, very afraid because it causes respiratory depression. You can never give it to somebody with COPD. Well, it's really not true. The only cases in 20 years of practicing palliative care, the cases of severe respiratory depression that I've seen have been usually because of a mistake. So somebody misplaces a decimal point and gives 100 milligrams instead of 10 milligrams. Or the concentration of an infusion changes. There's been a patient getting a morphine infusion at a concentration of 1 milligram per milliliter, and then the pharmacy changes the concentration to 10 milligrams per milliliter, and the nurse doesn't notice. That's usually when it happens, or when changing from one opioid to another and someone makes a mistake. Otherwise, respiratory depression is really quite rare. We try to avoid intramuscular administration. We avoid codeine and meperidine. Methadone is complicated and not available in Russian Federation, so I don't need to mention. And then, very important is knowing how to do equianalgesic conversion from one opioid to another. And this is an example. So my trainees at my hospital in Boston, I tell them, you have to have this table or one like it with you every day and a calculator. Usually they use their phone to calculate. I tell them, if you don't have this with you, go home, because you can't practice good palliative care. You got to bring this. If you don't bring this, you're not fully dressed. It's like coming to the hospital without your clothes on. You have to bring this with you. Because when you're switching from one opioid to another, or just from oral to intravenous or intravenous to oral, you have to know what you're doing. And this is, I can't remember all these conversions. I have to look it up. So I always have in my pocket my little table. Always. And that includes switching from oral or intravenous to the transdermal fentanyl patch. This makes it possible. Are there, does the Ministry of Health of Russian Federation have pain treatment clinical guidelines? Are they available? No. Yes? Does it have a table? It does. So everybody has access to a table like this? Yeah? Okay. Good. Now, I know that sometimes it may be difficult to convince your bosses about about using opioids for treating dyspnea. So when I teach around the world, I offer to give copies of papers to all of our physician trainees, so that then they can show their bosses, look, this has been studied, there's literature on this, whether it's dyspnea due to cancer or COPD or interstitial lung disease, there is data. This has been studied. And in fact, there are also consensus documents from the American Thoracic Society, for example, the American College of Chest Physicians, that say that opioid is essential for treatment of end-stage lung disease and for palliative care. Now, a lot of textbooks, even some palliative care textbooks, mention the use of benzodiazepines for dyspnea, to treat the anxiety associated with dyspnea. But I think this is a mistake for many patients. Most patients who are anxious because they have dyspnea should have their dyspnea treated. If you give opioid to treat the dyspnea in a patient with refractory dyspnea or a dying patient, their anxiety usually resolves with the dyspnea. They're only anxious because they're short of breath. You relieve their shortness of breath, they're not anxious anymore. And you don't need to give a benzodiazepine, which could result in delirium. If patients have an underlying anxiety disorder or have been taking benzodiazepine for a long time, fine. Then you can use a benzodiazepine. But if the patient is not already taking benzodiazepine and is clearly both dyspneic and anxious, treat the dyspnea with opioid, and often, actually usually you won't need benzodiazepine. Also, as I mentioned before, in order to avoid the risk of delirium, even if the anxiety persists after treatment of the dyspnea, if you're worried about delirium, haloperidol, where's haloperidol? It's up there somewhere. It's this, I think, right? Yeah. Haloperidol also has a mild anxiolytic effect. So you can use that instead of benzodiazepine in many cases without the risk of delirium. Haloperidol virtually never causes delirium. Oxygen, well, you know, oxygen you can use or not use. For severe refractory dyspnea, it's rarely completely effective. You don't need oxygen to relieve terminal dyspnea. Opioid is much better. Sometimes families don't want the oxygen taken off, and fine, if there's oxygen available, if it's in the hospital, you can use it, but it's not essential for relieving refractory dyspnea. Opioid is much more useful, and we try to get families to not worry about the oxygen saturation. So in the hospital, we try to turn off the monitors because sometimes families are just watching the monitor and not watching the patient and not doing the grieving that they could be doing. So we try to turn off the monitors. They aren't important. All that's important is how the patient looks and is feeling. Non-pharmacologic interventions, there is data that shows that a fan or a cool breeze can help to relieve dyspnea. I tried for about 15 years to get my hospital to allow us to just use a fan to put a breeze on the patient's face, but no, Harvard Medical School Teaching Hospital doesn't allow a fan. That's too simple. Now they allow it, but it took 15 years to convince them. Reduce the temperature in the room, limit the number of people, of course no smoking. Sometimes patients are more comfortable sitting up, for example, if they have a lot of ascites. Sometimes relaxation techniques are helpful. Okay, so what should we do about discussion? Is it going to be discussion? Should we have discussion now or wait till the end? Or because I'm about to move on to the next topic. So do we want to have any discussion now or? Yes? So then should I? So now I need interpreter. So question or comment about dyspnea? No question or comment.
Вопрос был из зала. В инструкции на морфин нет показаний одышки. В нашей инструкции.
So let me first ask, are there guidelines from the Ministry of Health for palliative care in general or only for pain relief?
Сейчас, на данный момент, только касается болевого синдрома.
Okay, so then my response would be to volunteer as an association of palliative care professionals to provide the Ministry of Health with concise, user-friendly, but comprehensive palliative care guidelines that include assessment and treatment of other symptoms, not just pain, so including dyspnea, nausea, anxiety, depression.
Сейчас на данный момент в инструкцию по морфину вносятся изменения. И, уважаемые коллеги, в том же плане мероприятия «Дорожная карта» одним из пунктов был именно пересмотр инструкции. Вот здесь Людмила Владимировна Шершакова, Московский эндокринный завод. И этот пункт о внесении изменений в саму инструкцию на морфин рассматривался не один раз, и сейчас еще первый раз был отклонен, и сейчас на рассмотрении. А клинические рекомендации, которые принимаются Минздравом по одышке, они планируются на 2018 год.
Thank you. I would just add that one needs to be very careful because we want to make clear that morphine should not be used to treat an asthma attack in a child. It's only for refractory dyspnea in patients with advanced disease and for dying patients. But for those patients, it's essential.
Еще вопросы?
Ну, возможность использования глюкокортикостероидов инъекционных при одышке, ну, можно ингаляционных тогда тоже рассмотреть. Глюкокортикостероидов инъекционных при одышке, злокачественного образования, метастатический процесс или локализованная опухоль, блокирующая крупные бронхи, вызываемая дыхательной недостаточностью вследствие этого. Спасибо.
Thank you. Yeah, so certainly for reactive airway disease, for advanced COPD, steroid can be useful, and steroid has many uses in palliative care. So if there's a tumor blocking anything, if there's tumor causing mechanical bowel obstruction, or tumor partially blocking an airway, steroid, and especially dexamethasone, because dexamethasone has the least mineralocorticoid effect of the steroids, can help to reduce edema around a tumor enough to sometimes allow the bowel to open again if it's been mechanically blocked, and maybe also to allow airway to open more if it's been blocked. And of course, for brain metastases, it can help to reduce edema and the effects of edema around a brain tumor. Steroid have many other positive effects. So it can improve energy and mood. That's why typically give one dose in the morning rather than every 6 hours or every 8 hours, because giving it at bedtime can disrupt sleep. It's a bit energizing. It can just make people feel better. Sometimes it can provide relief for neuropathic pain that no one really understands why, but it can help neuropathic pain. Sometimes it can help nausea. So it has a variety of uses. Of course, steroid has a lot of side effects, but in patients who maybe will only live for days or weeks, or maybe a month or 6 weeks, there's less concern about side effects unless the patient is already diabetic, because it will make the blood sugar go very high, or unless there's a concern about infection. So there are many uses, but yes, it can be useful for some causes of dyspnea, again, based on differential diagnosis. So that's a good question. Thank you. Again, this is a clinical decision based on the goals of care and on each patient's individual situation. If there's a patient who has a painful deep vein thrombosis but otherwise has a reasonable quality of life, certainly anticoagulant can be given. If it's a low molecular weight heparin, it means an injection every day. So we try to avoid injections in patients who are very close to the end of life. If it's a patient very close to the end of life and only have days or hours, and they have painful deep vein thrombosis, opioid will relieve that. Don't need to give anticoagulant. But if they may live for a while and they don't mind getting an injection, they can get low molecular weight heparin. If warfarin is going to be used, then theoretically they need to have their what we call INR, the INR, international, it's some kind of units. Theoretically that needs to be checked. And we don't like to draw blood from patients, and if they're at home, it becomes a burden. They have to go to a clinic somewhere and get their blood drawn, unless the mobile team can do it. So it's weighing the benefits and the burdens. If their quality of life is good enough, and either the blood can be drawn at home, or they don't mind going to the clinic, then they can take warfarin as well. So it depends on the goals of care and on the clinical situation. In some patients, it's more beneficial than burdensome. In others, it's more burdensome than beneficial. It varies. Yeah.
Eric, as you mentioned before, the dyspnea is a subjective symptom. And how could we start thinking that this dyspnea is refractory? How could we measure it, and when should we start doing morphine or other opioids to other patients?
Could you say it in Russian also?
Да. Вопрос такой, как мы можем измерить одышку, если это симптом субъективный, и когда мы можем считать ее рефрактерной, чтобы мы могли начать опиоиды? Должны ли мы задерживать их назначение и пытаться лечить чем-то другим?
Спасибо. It's refractory when the maximum treatment for the underlying cause is not effective at relieving it. So if a patient has COPD or interstitial lung disease and they're already on maximal therapy, they're already on inhalers, bronchodilators, they're on chronic steroid, any of the newer immunotherapies, but still have dyspnea, that's refractory dyspnea. If they have cancer with lung involvement, either a primary lung cancer or pulmonary metastases, and they've had maximum treatment for the cancer, and there's no more good treatment options, and they have dyspnea, that's refractory dyspnea. And again, sometimes it's a question of goals of care. So, for example, with very frail elderly who have some dyspnea, it might not be that they have such severe untreatable lung disease, but their goal of care becomes comfort only because they're very frail and have many medical problems and just don't want to go back to the hospital anymore. And they become dyspneic, maybe from metabolic acidosis or aspiration. It's not that it's theoretically untreatable, but they only want to focus on comfort at that point in their life. So then in that case, rather than sending them back to the hospital and doing mechanical ventilation, it's okay to or if they get pneumonia, right? I mean, some patients who are very frail and very, very sick or very, very old, and they just want the goal of care to be comfort, and they get a pneumonia. Theoretically, it's treatable, but they just want to be comfortable, so then maybe no need for antibiotics. Just make sure that they're comfortable, and in that case, opioid can be given as well. So it might be refractory dyspnea because there's no more treatment for the underlying disease, or it might be because there's been a decision, ideally involving patient or family or both, and whatever clinician is caring for the patient, that the goal of care is only comfort. Yeah. Just one way over there.
Вопрос о галоперидоле и о побочном действии галоперидола.
Я хочу сказать, что тут прозвучал такой ответ, что если у больного есть дементное расстройство, то мы должны использовать галоперидол. Ну, я в своей практике и пользуюсь ним, и к тому же у меня психиатры консультируют. Галоперидол обладает эффектом сковывания. Он сковывает больного. Даже в малых дозах быстренько эффект накопления, он его сковывает, он его укладывает. Психиатры никогда не используют галоперидол без циклодола. Вы все должны это знать. Ну, знаем, да? Скажите, пожалуйста, а при одышке, если у нас больного принимают участие в дополнительные мышцы, там, у него одышка, если мы его еще скуем, то, может быть, мы там дементный синдром снимем, а вот одышку мы наоборот увеличим. Как вы считаете?
She's saying it affects muscles?
Вопрос об экстрапирамидных расстройствах на фоне галоперидола, да? Вы об этом?
So haloperidol does not affect muscle movement. I'm not sure I understand. Haloperidol is not a neuromuscular blocker. It doesn't affect muscle movement. I think, I'm not sure.
Экстрапирамидные расстройства.
So first of all, the doses of haloperidol that are typically used for treating anxiety or nausea are quite low. So 0.5 milligram or 1 milligram is often all it takes. For treating delirium, especially if there's severe agitation, sometimes the dose needs to be higher. But if I understand correctly, you may be talking about extrapyramidal side effects, which can develop usually over months or years. And in this in the population we're talking about, they often don't live that long. So the patients who developed, for example, tardive dyskinesia, which is a severe complication of chronic neuroleptic use, whether it's haloperidol or another one, that may develop over months or years. And that's, I've never seen it in palliative care. I only see it in the chronic psychiatrically ill. There is a dystonia, dystonic reaction that occurs sometimes with neuroleptics like haloperidol that's easily reversed by giving an antihistamine. Antihistamine. And it's relatively rare. Actually, I've been, I use haloperidol virtually every day in my practice, and I've only seen it. Actually, it happened to me once when I was a resident, a patient. And we went like that, and I gave a dose of diphenhydramine, and it was resolved. So it's actually a very safe drug, and movement disorders are virtually never a concern for using haloperidol in palliative care.
Доктор, спасибо большое вам за доклад. И у меня вопрос по терапии рефрактерной одышки опиоидами у нейромышечных больных. Вы сказали, что для меня было открытие то, что можно использовать в терапии не только морфин, но и другие опиоиды. В нашей практике мы не использовали с целью коррекции одышки другие опиоиды, кроме морфина. И вопрос по поводу перерасчета дозы, потому что в своем докладе вы показали перерасчет анальгетический эквивалент, и там были другие дозировки. То есть так же, как и вы, средняя дозировка, которую мы использовали, это было 10 мг в сутки парентерального морфина, средняя дозировка. Максимальная, которую мы использовали, это было 40 мг. А в вашей таблице перерасчет дозы, там был морфин 50 мг суточный, перерасчет на фентанил 25 микрограмм в сутки. Вот желтым выделена таблица. Ага. Вопрос в том, если мы используем фентанил конкретно для контроля одышки, то какую дозировку трансдермальной системы использовали вы у пациентов для коррекции одышки без болевого синдрома?
Okay, thank you. As I mentioned, I tend, for treating dyspnea, so if there's a patient near the end of life who suddenly gets very severe dyspnea because they just blocked their airway just became blocked, or they're hemorrhaging or something, then I treat very aggressively with intravenous morphine or intravenous opioid. But for a patient who has end-stage lung disease and has dyspnea at baseline, or dyspnea with minimal movement, then I typically will discuss with the patient about using opioid, and I will begin with half of the usual dose that I would use for treating an adult who has pain. So an initial dose of oral morphine, if I'm going to give it around the clock for pain in an adult, would be 5 milligrams orally every 4 hours, or about 2 milligrams intravenously every 4 hours. For dyspnea, I would start maybe with 2 milligrams orally or 1 milligram intravenously, something like that, very gentle. And then observe the effect and adjust it as needed. I want to be very careful at the beginning because I don't want the patients, if the patient already has a high PCO2, I don't want to make it go higher. I just want to relieve the dyspnea. So the problem with switching then to a fentanyl patch is the dose. So a 25 microgram fentanyl patch is equivalent to about 50 milligrams per day of oral morphine, or 17 milligrams per day of intravenous morphine. So that would be the equivalent of about, let's see, divided by 6, so it's about 8 milligrams of oral morphine every 4 hours. If the patient is not already on 8 or 10 milligrams of oral morphine every 4 hours, then a 25 milligram fentanyl patch will be too much. In the US, we also have a 25 microgram patch will be too much. In the US, we also have a 12 microgram per hour patch. But I don't believe, you have 12? Ah, okay. So then if you have a 12 microgram patch, then if the patient is on just about 4 or 5 milligrams of oral morphine every 4 hours, then you can switch to the fentanyl patch. But you need to use this table. Now, there's one other slight complication here. I don't know whether I should mention it, but maybe I should. Is the concept of incomplete cross-tolerance. Incomplete cross-tolerance to opioid, is that familiar? Dr. Nevzorova? No? Okay, so maybe this term is not familiar. Incomplete cross-tolerance. Here's the idea. There are a variety of opioid receptors in the body. Mu receptors, kappa receptors, but there's subcategories. There's many different opioid receptors. And each opioid, morphine, hydromorphone, fentanyl, oxycodone, they all affect the different opioid receptors to different degrees. So if a patient has tolerance, is that concept familiar? Opioid tolerance? No. Yes. So if I'm a patient and I've been taking morphine for several months, and I have a tolerance now to morphine, and you decide, and I'm taking it because I have COPD, and I have severe COPD like the patient you saw, and I have shortness of breath at baseline, and you decide you're going to switch me to fentanyl. Fentanyl does not affect the same opioid receptors to the same degree. It maybe affects some of the receptors that morphine affects less and some more. So the patient will have some tolerance to fentanyl, but less tolerance than I have to morphine. Therefore, when you switch from morphine to fentanyl, you have to use this table, but then you can decrease the calculated dose of fentanyl by about 1/3 because of incomplete cross-tolerance between opioids. I'm not sure, was that clear? So once again, any different opioid, morphine, hydromorphone, fentanyl, any of them, they affect opioid receptors, but they don't affect the same receptors to the same degree. So I might be tolerant to morphine, but I'll have less tolerance to another opioid, whether it's fentanyl or oxycodone or hydromorphone. So if I switch from morphine to any of those, I need to use this table and calculate the dose, because these doses are calculated just by giving one dose of one and one dose of another. That's how these tables were developed. It didn't include the concept of tolerance in making these tables. So use the tables, but then you can decrease the dose of the second opioid by about 1/3 because of incomplete cross-tolerance. One of the ways that this is very useful is if patients are developing neurotoxicity to one opioid. So for example, you have a patient with very severe pain, and you're increasing the morphine dose and increasing it and increasing it and increasing it, and then they start to get myoclonus, that shaking that you get sometimes. You can switch to another opioid, and because of the concept of incomplete cross-tolerance, you can reduce the second opioid by about 1/3 reduce the calculated dose, and maybe they won't have myoclonus anymore. So, what was the original? Oh yeah, switching to fentanyl. So you have to use this table, and if the patient is on such a low dose of morphine that there's no equivalent transdermal fentanyl patch, then you can't use fentanyl because it'll be too much for them. So there was a question about the fact that when you apply a transdermal fentanyl patch, it takes time. It can take as long as 16, 18, even 24 hours to take full effect because it has to be absorbed. And by the way, in this patient, where is he? He's hiding. This patient is very cachectic. He has very little fat underneath his skin. Fentanyl is lipophilic. To be absorbed, to be properly absorbed, there needs to be fat underneath the skin where the fentanyl patch is placed. If there's no fat left, and this man doesn't have much fat left, then fentanyl patch may not be a good choice because it may not be properly absorbed. If the patient is extremely cachectic and has no adipose tissue under the skin, if the patient is sweating all the time or febrile all the time, fentanyl transdermal patch is not a good choice because if they're very cachectic, they won't absorb it properly. If they're sweating, the patch may not stick to the skin. If they're febrile, they may get too much too quickly. So there are some situations where fentanyl patch, transdermal patch is not ideal. Also, if you're going to switch, the question again was that it takes time for the fentanyl to take effect. So if you're switching from, let's say, continuous morphine infusion to fentanyl patch, I suggest don't just stop the morphine infusion and then apply the patch. It's better to overlap. So ideally what you could do is put the patch on, continue the infusion for another 3 or 4 hours, let's say 4 hours. After 4 hours, reduce the infusion by 50%. And then after 8 hours or so, or 12 hours, then you can discontinue it, but also make sure that their rescue dose is still available. Because again, it may take as long as 16 to 24 hours for the transdermal fentanyl to be fully absorbed and take full effect. And the same rule applies if you're switching from a transdermal patch to an oral or intravenous mode. Recognize that the effect of the fentanyl will only gradually decline over 24 hours. So if you take off the patch and immediately start the equivalent dose of morphine, in an hour or two, the patient might be very sleepy. So you can start the morphine dose at a lower dose than the target dose, and then increase it over 12 hours. So.
Нет, у нас получается 15 минут.
Я короткий вопрос. Можно еще один вопрос? Все-таки препаратом выбора при лечении одышки именно является морфий или фентанил? Или все-таки препаратом выбора именно при одышке является морфий? Фентанил используется в крайних ситуациях?
Any opioid works fine for dyspnea. The differences are that in the intensive care unit, they often prefer to use fentanyl for a variety of reasons. One is that the patients are often hemodynamically unstable, their blood pressure may be low, and because fentanyl has a very short duration of action, it's easier to titrate. So fentanyl is typically used more commonly than morphine in intensive care units. Also, patients with renal failure, fentanyl is a little bit easier to use in patients with renal failure because the dose does not need to be adjusted, and there's no increased risk of neurotoxicity with renal failure. But in terms of relief of dyspnea, there's no difference between opioids. They all are effective for relieving dyspnea. Yeah. Okay, should we stop now? 15 minutes, okay. Any more question, or shall I go on to talk about life-sustaining treatment? Okay, so 15 minutes on optimum use of life-sustaining treatment. Okay. Okay. So I want to tell a little bit of a story. I want to give a little bit of history of life-sustaining treatments because I found this extremely helpful in understanding the dangers of causing more harm than benefit of life-sustaining treatment and in helping to figure out how to use them to maximize benefit and minimize the harms. So a little bit of history, and then if there's time, I'll talk about principles for deciding how to optimally use life-sustaining treatment, and then practice guidelines. Here's a case of a 75-year-old man, Mr., not Tavarish, Mr. A, okay. 75 years old, he has severe COPD, he has coronary artery disease, he has chronic kidney disease, diabetes with peripheral neuropathy, so he has pain in his feet, and mild dementia from some small strokes, all related to his vascular disease and his diabetes. He's retired, a working class man, he lives in a retirement home. His children and grandchildren do not live close by, they live in Samara. He worked as a truck driver and he didn't have consistent medical care. So now he gets hit by a car, he has a femur fracture, and after surgery he has cardiac arrest. So then he gets cardiopulmonary resuscitation, then he's on a ventilator in the intensive care unit. He doesn't wake up, and they realize that he's had a stroke when he had no blood pressure. His blood pressure remains low. His kidneys fail because of poor perfusion, so hemodialysis is started. They can't seem to get him off the ventilator, so they do a tracheostomy and place a gastrostomy tube for feeding. Now it's 1 month after his arrest, and he doesn't seem to recognize his family members when they visit, but the family says, you have to continue all life-sustaining treatment. This is a very common scenario around the world, wherever there is intensive care units. So what do you do? So remember Mr. A. What happened here? Going the wrong way. Okay, so a little bit of history. First, start with hemodialysis. It was invented in the 1940s and entered common use in the 1960s. And then in the 70s in the US, Congress decided that the government health insurance would pay for hemodialysis. So it was decided that everybody who has end-stage kidney disease should get hemodialysis. But then there was a man who was very demented, who became very demented, and he was being kept alive for years, even though he didn't recognize anybody, he didn't have any way to interact with anybody, he had end-stage dementia, and the family said, stop, don't do this to him anymore. The doctors refused. They said, we have to continue. So the case was argued in court, and finally the court allowed that hemodialysis could be stopped at the request of the family. So that was one of the first cases where the court had to decide that the family has the right to demand that life-sustaining treatment be stopped. What about positive pressure mechanical ventilation? This was developed in the 50s and 60s during the polio epidemics. Someone had the idea of, instead of an iron lung, the old iron lung negative pressure ventilation, of putting a tube in the trachea with a cuff around it to make an airtight seal, and giving positive pressure ventilation, and then ventilating with a machine. This entered standard of care in the 60s and 70s, and that's how intensive care units were created. They were initially places to put patients who were on ventilators. And again, like with hemodialysis, it was just assumed that you can never stop. Once you start mechanical ventilation, you can never stop it. That would be like killing a patient, right? Well, that's what we thought in the 60s and 70s. And then there was another patient who was in a permanent vegetative state, a young woman who had an overdose of alcohol and some other medications and had no consciousness of anything, only brainstem function. And after years of this, the family said, enough, enough, stop the ventilator. The hospitals refused, the doctors refused, and again it had to go to the court. And the court finally agreed that the ventilator could be stopped. And what happened? Did she die? No, she lived another 9 years because they continued to give artificial nutrition and because she had very good nursing care. But the precedent was set that you don't always have to continue mechanical ventilation. What about cardiopulmonary resuscitation? Invented in 1960 and deemed usable by anyone, anywhere, and useful for anyone, anywhere. So in the 1970s and 1980s in the US, if you were training, you were a young doctor in the hospital, you were very strong because you were doing chest compressions every day, all day. Everybody who had cardiac arrest had to get chest compressions. Useful for everybody. And then, beginning in the 70s, some people began to feel very uncomfortable. What are we doing? Somebody who's 95 years old, dying of cancer, and we're beating on them. We're breaking their ribs. We're cracking their sternum. We're ending their life with an act of violence. What are we doing? So even in 1976 came the first guidelines for not doing CPR. Whoops. Yeah. In 1976 were the first guidelines for not doing CPR. And finally, artificial nutrition and hydration. And this one is often more difficult emotionally, both for clinicians and for families. So again, this has been used for millennia, but it only entered common use in the 1970s when a new method was invented to prevent leakage into the peritoneal cavity. And then in the 1980s, there was developed the endoscopic, the percutaneous endoscopic gastrostomy. And again, there was the idea, well, you have to do this for everybody who can't eat anymore. As late as 1983 in the US, 2 doctors were indicted for murder for stopping IV hydration and nutrition from a neurologically devastated man at the family's request. Intravenous, more invasive than via gastrostomy. Now, they weren't convicted, they weren't sent to prison, but still, it can be a little bit upsetting to be accused of murder. So there's been big debate about this. And then again, there were some court cases where the family insisted that the artificial nutrition should be stopped from a patient who's being kept alive with no brain function. And finally, the courts agreed that artificial nutrition and hydration also can be stopped, either if it's more harmful than beneficial, or if the family requests it. So the point I want to make, and the same could be said about pacemakers and implanted defibrillators and any kind of artificial or any kind of life-sustaining treatment. The point is that it seems that when new methods of sustaining life are invented, we have an idea, well, we have to use them. And then with time, we recognize that they can be more harmful than beneficial. So with time, it's been recognized that they can be more harmful than beneficial, and we can use them or not use them depending on the balance of harms and benefits and the preference of the patient. How much time? Finished? Okay. So, yeah. Well, let me just make one final point. And this is the one I alluded to earlier. So there are a lot of principles, such as autonomy, but this is what I wanted to emphasize. Goals of care. Is that what this says? Here. Goals of care. This may be somewhat unfamiliar idea because every patient is different. Two patients with the same disease, the same degree of disability, like Mr. A, or let's assume that Mr. A, because of his diabetes, he needed amputations and couldn't walk anymore. For some patients, that would be an unacceptable quality of life. Can't walk anymore, maybe can't work anymore, can't drive anymore. For other patients, that's still okay. So everybody's different. We need to understand the patient's values, and we can only do that by talking to the patient, or if the patient can't talk to us, talk to whoever knows the patient best, a spouse, a domestic partner, family, and then figure out what are the best goals of care based on the clinical situation, the expected course of the disease, and the patient's values. That might mean in some cases we should protect the patient from CPR. We should protect them from going through resuscitation, for being intubated and put on a ventilator. Or it might mean in some cases, well, their quality of life is okay, so they would agree to be intubated and be on a ventilator for a few days, maybe, to see if they develop a pneumonia or an exacerbation of their COPD, to see if they can get better again. And if they can't, then give them medication to prevent suffering and stop the ventilator. That's also a goal of care. It's allow for a time-limited trial of life-sustaining treatment. And for other patients, they just want comfort. They don't want CPR, they don't want mechanical ventilation, they don't want hemodialysis, they don't want artificial nutrition, they want to be comfortable. So based on the patient's values, the expected course of the disease, figure out the goals of care, and that will help you decide how to use life-sustaining treatments. And last point, in my country, we had an idea 40 years ago that once you start a life-sustaining treatment like mechanical ventilation, you can't stop it. But now it's very well accepted that if a treatment has been started, but now it's no longer providing benefit, or it's now more harmful than beneficial, it should be stopped. And if that means that the patient has to receive medication to make sure they don't suffer when it's stopped, then they should get that. So if there's a patient who's on a ventilator and the family says no more, or the patient says no more, but I don't want to suffer, then I'll pre-medicate that patient with as much opioid and other medications is, like benzodiazepine, midazolam, maybe propofol, whatever it takes to make sure that patient doesn't suffer when the ventilator is stopped, and I will withdraw it. There's no ethical or legal difference in the US between not starting a life-sustaining treatment that's not desired or not beneficial, or stopping it once it's already been started. So I'll stop there. And again, if there's comment or question, glad to receive them. Thank you.
Спасибо огромное, Эрик. Ощущение, что совсем наше далекое будущее, в 83-м, 70-м году, обсуждение этих случаев, которые мы еще и не начинали. И вентиляторы у нас не запрещены, уважаемые коллеги, и это прекрасно, потому что остальное сейчас как раз в том месте, когда мы не можем остановить ИВЛ, когда мы не можем остановить искусственное питание, когда мы не знаем, капать или не капать, когда родственники не могут дать своего пожелания как итоговые решения, потому что они не являются законным представителем, потому что пациент, несмотря на то, что он без сознания, не лишен дееспособности. И в этом случае включается наша адекватная логика. Да, что делать? Иногда мы прикрываемся или защищаемся тем, что пациент не является, родственник не является законным представителем. Иногда мы ищем каких-то других слов. И действительно, когда весной этого года команда Эрика знакомилась с нашей ситуацией по паллиативу, первый вопрос, который задали нам коллеги, а как защищен пациент и врач? Какие законодательные акты есть именно в этом направлении? Да, потому что история паллиативной помощи в других странах имеет некое другое, уже более дальнее развитие, нормативно-правовая база, а у нас только 6 лет. Поэтому мы к этому придем, а иначе мы не сможем существовать и оказывать помощь. И еще раз скажу, хорошо, что вентиляторы разрешены и кислорода много, и свежего воздуха, и холодного тоже мы можем обеспечить. Уважаемые коллеги. И, кстати говоря, про пластырь 12,5 я просто писала. К сожалению, пластырь 12,5 зарегистрирован в Российской Федерации, но во всех субъектах его заказывают. 25 вот с 25, а 12,5, к сожалению, не каждый из нас видел. Да, то есть не во всех субъектах эти 12,5 микрограмм пластыря в час есть, к сожалению. И про 1/3 дозировки. Да, в клинических рекомендациях по боли в таблице перерасчета доз прописано, что при переходе на другой препарат уменьшайте дозировку на 30%. Да, обратите, пожалуйста, внимание еще раз на это. Спасибо вам большое. И, кстати, про черезкожную гастростомию мы ведь до нее даже еще ведь и не дошли. То есть основная гастростома – это вот те самые петцеровские катетеры, совершенно не эндоскопическая гастростома. Мы только мечтаем об эндоскопической гастростоме, потому что, к сожалению, она недоступна. Вот в Новосибирске мы говорим, какое счастье делают эндоскопическую гастростому. То есть, к сожалению, мы этого пока тоже не видим. Да, спасибо вам, уважаемые коллеги. И, Эрик, огромное вам спасибо. Спасибо, что вы с нами. Мы счастливы.